I think most of the things in pediatric, when they started doing, there always are controversies. When to put lens, when to do surgeries. Should you do the squint surgery at the moment you see the patient squinting the eye, or should you wait? Refraction to be done before or after. If you seeing from a private practice set of view, people will operate immediately, right? Whereas when you do it properly, how to go about proper things and how to get the visual assessment. I think it's very important because how you address a disease is important. So it should not change actually. The USP should be same for each and every patient. They should have protocols, set protocols which should be followed. The controversies happen only when the people don't follow the regular regulations for the surgeries and for the treatment of the patient. Timer की ज़रूरत है आपको?
नहीं, it should be.
Okay.
Otherwise, people will go out of.
नहीं मैं रोक लूँगा ना. अच्छा ठीक है हाँ ठीक है. So 10 minutes each.
So आपको time लगा दो बेटा.
Now that Dr. Shukla is here, I can start. Now I was waiting for you. And you, I hope you'll sit here till the end of the session. In AOS, I mean, मैं तो हूँ ना.
मैं हूँ ना.
मैं हूँ ना. सही बात है. Okay, so now the first topic we're going to open up is how to actually assess the vision of the child, because that makes a difference. There could be a naughty kid who's closing his eyes and is just a naughty kid and you think he's blind and you're doing all these MRIs and scans. So you have to be smart enough to pick up what is the visual status of the patient, because that is going to help you after surgery also, be it a cataract or a strabismus, to check out what the vision the kid has attained now. So over to Professor Pradeep Sharma, our guru, guide,
Thank you,
and a friend. So,
Professor Sudarshan. I think we are really blessed to have a good audience, because these are the dedicated people who have come early morning. Now, even if there is one dedicated person, the teacher feels obliged to teach. Why is a pediatric ophthalmologist needed? Who is a pediatric ophthalmologist? We are all probably doing cornea, lens, uvea, glaucoma, whatever, and helping the eye. And child also has an eye. Is it the same thing? What I envisage is that in adults, the vision is restored instantly as the development of vision is not affected. It is not the same in children. In children, the assessment and restoration of vision requires special techniques. And that is why we need a pediatric ophthalmologist who would be doing or having an understanding of this. We see binocularly not because of eyes, but because of the brain, the cortex behind, which is getting the images, and what we see is in the cortex. The vision is not something which is developed de novo right since birth. It is developing in the initial part of our first 9 months very drastically, and then gradually till about 5 years of age. Now this vision development, I generally say, is like language. Vision is a cortical language, which you are learning best in the first 5 years, like our mother tongue. Later on, it is possible to learn any language. Chinese you can learn today also, but with lot of difficulty. The same is true for vision. And if something goes wrong in that creative phase of 5 years, there is something which will be called as amblyopia. That's a neurodevelopmental anomaly of vision. To my mind, amblyopia is a neurodevelopmental anomaly of vision, and it involves 3 to 5% of general population. All of you must be knowing the definition of amblyopia. I don't want to go into that, but remember it can affect one or both eyes. It is because of the best refractive correction. It is having no obvious pathology still left, like cataract may have been removed and still there is a vision problem. Then only we say it's an amblyopia. And the visual deprivation or an abnormal interaction is the cause. And the best part is it is correctable if treated in time. The causes are there in the books, we don't want to go. How to detect it? A simple thing which you can do in a child, if he has a squint, then we can see we cover the good eye, he will revolt. If you cover the bad eye, there is only a very slight response. See the response in the third picture. When you cover the good eye, he will have a total revolution. So that indicates that the vision is poor in that. If you do not have a squint manifest, you can put a prism in front of the eye and know which is the preferred eye for fixation. So fixation preference is one method. You can also observe. Now this child is observing you from a side. He is fixing with the right eye in adduction. If you cover this eye, he will immediately shift his attention and have the left eye in adduction if the vision is equal in both the eyes. If not, then he will have a revolution. You need to have fixation devices like toys, which you should carry in your pocket or maybe in your bag, and many, because the attention span of a child is poor. So you can judge by simple method like a central steady maintained fixation, following the eye movements horizontally or vertically, which is there in the first month, and vertical movements by 2 months of infancy. So you can detect the child's vision, what he is having. Another objective way is to see the Bruckner's fundus reflex. This is basically detecting for amblyopia-genic cause. If there is any media opacity, if there is any squint or a high refractive error, you can easily pick it up by the Bruckner's reflex. So this is also the basis for the photo screening, and that is why it's a very valid and fundamental test which we can do. But then these are the photo screeners, examples shown on the Bruckner's, how it looks if there is a hyperopic crescent, if there is esotropia fixing with the right eye. You see, this is the brighter reflex is to the eye which is squinting, and this is esotropia fixing with the left eye. The brighter eye is become this. You can do a simple testing of binocular if the child is able to tell you that he is seeing a line, and you will know whether each eye is equally seeing or not. But a much simpler thing which I generally advocate is a 2-pencil test, which is very, very good for detecting binocular vision. It is as good as Bagolini glasses and much simpler to understand by the child. He has to play. You give him a pencil and you hold the pencil, and if you ask him, you will see this, that he is able to do that thing very easily if he has both the eyes functional. Okay. But coming to the specialized test, the best for amblyopia detection is the recognition acuity test. But we have detection acuity tests like Catford drum, Boyk-Candy cards, and we'll talk about them. The resolution acuity can be tested by the preferential looking test. The standard for the infancy up to 18 months is the Teller acuity cards. But Teller acuity cards are not available in most places, and these are what you'll see. They have typically a screen, but you may just use the card which is having resolution gratings and a pattern on the other side, and there is a small peephole through which the examiner is looking, and the screen is there to prevent the father or any attendant who is not supposed to guide the child which way to look. So this is detecting the basis of the looks, and we have used this method to detect the vision in children in our country. At around 11 or 12 months of age, the vision is equivalent to 6/24 in normal children. But if there is a refractive error, then it becomes 6/72 at 11 months, about 6/202 if there is a strabismus, esotropia, and it falls down to 6/2000 if there is a cataract which is more than 3 millimeters. We recently have developed a digital version of Teller acuity cards. A patent has been filed, and I presented this at the American Academy, Chicago, this time. This is using a laptop, and this is using the gratings generated on the laptop, but it uses the camera of that, and it is actually determining the gaze of the child. You do not have to ask the child anything. He has to just keep on looking at the laptop and sees the gratings as they change. And there is a robust algorithm which we have generated with the help of MIT group, and in which these things will be done and the gaze is being detected. So this is, if this video will show you a real-time test. Now this is a screen on which, now this is detecting my face and the eyes, then it has started giving the gratings. It will keep on reducing to the finer and finer gratings if I am able to look at it. It will keep on going, and this will take just 1.5 minutes to tell us the vision. Now it has become finer and finer till the time the person seeing is able to see. And all the time the gaze is being detected by a very robust software which is seeing that. Keeps on going till the time there is either a wavered response or a definite response. And then finally it will give me a it can go back. If you are not seeing properly, it may give you the more broader gratings. And finally, it will come to a conclusion, what is your level of visual acuity. And this is how it will give me that this is the visual acuity. If I see here, this tells me here 30 cycles per second. This is how the number of responses have been picked up, and these green are the right ones, the red are the wrong ones. So it is generated, and this is 30 cycles per degree. So this is how we can do. But otherwise, we have OK and drums. We have the Okno-Vis, which we had generated, but now we have not been pursuing it. Catford drum. We have the sweep VEP paradigm because vernier acuity is better for detecting even cataracts. These are the resolution and vernier gratings. These can all be used on the Digitech format also. So the basic format that we have developed. For children who are older than 18 months and up to 3 years, the Cardiff acuity cards based on the principle of vanishing optotypes, so that the same size optotype becomes vanished when you are seeing it at a particular, more than particular distance. So we'll be able to find out what is this visual acuity, and we again can find out what is the visual acuity in different ages and of different children. Then we have the Allen's picture cards, the Sheridan-Gardner group of tests, the Snellen picture chart, which most of you may be having, or the HOTV cards. In 3 to 5 years, we can use the E chart, the tumble E, or the E on the Snellens. The ETDRS charts are the standard for research purposes, and the near vision charts are again possible for children. The vision screening, according to American Academy and the American Association, age-wise is on this chart. That what we can do, birth to 6 months, we can detect cataract, strabismus, structural defects by red reflex test, corneal light reflex, or external examination. 7 to 12 months, we can add with the fixation and follow-up movements, and still we can, 1 to 5 years, we can do a visual acuity testing as well as stereo acuity testing. And the stereo acuity you can do with the TNO, the red and green glasses, and the Polaroid test with the help of Rendot. We have for both distance and near. These are the Frisbee-Davis distance test and the distance Rendot. Finally, to conclude my talk, I would say the goal for us is not 20/20 vision. We have to restore the binocular vision and stereopsis. Each and every ophthalmologist is required to do this, be it a cataract surgeon or a glaucoma surgeon or an oculoplasty surgeon. He has to ensure that the vision is there in each eye and both the eyes are aligned so that we can have binocular vision and stereopsis for our children of each and every age group, so that he can see a 3D movie, 3D TV, and also if he becomes an ophthalmic surgeon, he can do 3D surgery in future. Thank you all.
Thank you, Dr. Sharma. That was fantastic. So he's got the ball rolling, and I think vision is what we try to promise to the patient, and that's what the parents expect. We want vision. A little misalignment in eyes might be okay still. If the vision is not there, they're not going to be happy. Thank you very much. And Dr. Sharma has to leave to the other hall. If you have any question, you can go to the other hall to ask him. It's okay. I know. Any questions?
He said they can go to the other hall.
I know. I was just because it was so clear. I think nobody should have a question. Take these pencils. That's a pen, sir. 2 pencils.
My finger can also work as a pencil.
No.
Now, you have to just touch my fingertip with that.
One eye closed.
Okay? Now cover your left eye.
Sir, he's amblopic. Yogesh is amblopic.
Now you have to do it, okay? Now do it.
No. Sir, इसको ले लो अंदर. Recruit him. Recruit him. Recruit him.
We will find out today. So this is a very simple test. On the bedside you can do it with both the eyes open and with one eye closed. Because then you will know the difference. What is the response if his vision is poor in one eye? So he may have, and keep on moving beforehand. Don't keep on moving when he is doing.
Dr. Shukla, आप अपना slide ready कर लीजिए. By the time he's answering.
This is testing binocular visual acuity.
Of course.
Not vernier.
It's not a vernier. It's not
this
a
is binocular vision.
It's not a vernier, it's
Binocular
a vision actually.
Right?
Yeah, yeah, sure.
Maybe afterwards, if you have, we can have more. Thank you. Bruckner's is basically using your ophthalmoscope at 1 meter distance with the larger aperture. Let the light fall on both the eyes, and you will see the red glow. But at 1 meter distance, it will shine on both the eyes and compare the reflexes. That's as simple as that.
I'll show you a video in my talk. So if you're sitting here by the time, welcome, sir. That was a very enlightening, yeah. And we're going to take Yogesh Shukla for the surgery, sir, cataract, I think. Refer to TTL. Okay, now, so are you talking about the controversies or debate, Dr. Shukla? You're going to talk about controversy or debate? I mean, there are two options.
But ये the topic, I mean the theme is both
So-
controversies and debates. नहीं ये करो,
So
मैं बता रहा हूँ.
you will be stressing on both.
Myopia.
No, controversy or debate.
Debate.
Okay.
क्या कर रहे हो यार?
So he's having a debate with the. Okay. So Bruckner, basically, first binocular vision. Let's go to the pencil test. When you see, look at a point of regard, you draw a line from the point of regard to the macula, to the fovea actually. That's the shortest distance, that's the visual axis. So if both the visual axes are coming to the corresponding part of the retina, then you get the image as one. The moment it shifts out, you have diplopia. Fine, so if I squint, the corresponding points of the retina stimulated by the same object will be seen as double. Is that right? So that's the basic for it. So if you take all the corresponding points on the retina for one object and draw arc, it becomes a horopter. So in front and behind the horopter is called the Paname's area. So anything which comes a little up or a little back can still be fused with the validity of your eye. So that Paname's area is what you're trying to stimulate. Right? So there's a disparity, horizontal and vertical. So earlier the thought was that it's only the horizontal disparity which causes the depth perception, and that was picked by a vertical pencil test. So all the Western literature talks about vertical. It's coming from the vertical. But when you come from the vertical, you see the horizontal shift. When you're coming vertical, the difference between two will be horizontal. It's not vertical. But Dr. Pradeep Sharma is talking about is a vertical. So he says in both the meridians it can be seen. So that's a difference in his test. But I think it's still gold standard to do a vertical to pick up the horizontal, because all the studies in Von Wooden until now in all the Western books are on the horizontal disparity. So is that clear? Bruckner's I'll tell you when my talk comes. Dr. Shukla, all yours. Was I right in the statement?
Oh, yes.
Good.
So I would be talking on myopia in children, recent trends in management and also debate. Now, myopia is the most common refractive error and so prevalent that it has attracted the maximum studies worldwide. A recent study by National Eye Institute USA showed that the incidence of myopia in general population has grown from 25% to 45% in the recent years. In the last decade, it has doubled. Nearly 100 million children and 1.5 billion people worldwide are myopic. Can you imagine 100 million children and 1.9, almost 2 billion people worldwide are myopic. And it is estimated that in the next 10 years, myopic persons would be 2.5 billion. The myopic children would be 2.5 billion. You see, you can understand that. Now, another study has speculated that unless strong action is taken, by 2050, half of the world's population would be myopic. By 2050, half of the world's population would be myopic. So it is an epidemic. Projections estimate we leave from one point. Okay, can this alarming epidemic be slowed down? Now, looking at the worldwide figures, a whopping 70 to 90% prevalence exists in some Asian countries, 30 to 40 in Europe and America, and only 10 to 20% in Africa. Why? It's a big question. Since myopia is such a massive public health problem and efforts to control its progression has been futile, it has generated the maximum interest regarding pathogenesis and methods to control myopia progression. Now, I'll just fly over some important points because it has bearing on the management of it. See, the first and foremost cause or reason for myopia is hereditary. We cannot deny it. The major chunk of myopia, and especially the progressive myopia, is hereditary. Nutrition, near work, outdoor activity, biochemical changes, refractive correction, seasonal variation, and illumination. These all factors have been implicated in the progression of myopia. Now, some of them are debatable, and some of them are well understood and documented, but some of them are still debatable. Anyway, now most of the focus now for the prevention of progression of myopia has been on basically these factors, that is lifestyle changes. Now, spectacles, bifocals, contact lenses, defocus contact lenses is another new term which has come, environmental conditions, pharmacological agents, and orthokeratosis. These are the modes of management. And well, half of them are debatable because some of the people do not agree that this has a strong bearing on the progression, but the research has proved some of them. Now, the newer paradigm of management is focusing today on three main areas, and that is environmental conditions, lifestyle changes, and pharmacological agents. Now, what are these? Now, it is a lot of stress is now being given on the environment. Environment means the space in which we live, the space in which we work, and the space which we abound. Now, it has been shown why in Africa it is only the least myopia and least progression. Because from times immortal, we have been wanderers. The human being and the eyes of the human being has been programmed not for near work, but for distance. We have been, natural wanderers, and we have been, the people in the ancient times have been wanderers basically. They are nomads, they were living in, mountains and green meadows and working in fields. That was the outdoor activity they were doing. So eyes have not been programmed for so much of near work which you are now doing. So this is a very strong correlation of myopia which has been documented, and it is not debatable, it is proved. And what is this? Arey bhai, ye.
You have video there, is it?
No video.
Oh, the final photograph has come. Aren't you late? You should have come at 8 o'clock.
ये कुछ को आगे चल नहीं रहा है ये.
No, but that's not fair. That's not right. If the session starts 8 o'clock, you have to be here at 7:45, please.
So what क्या हो गया भाई? So what has been basically that it has been now proved that 6 hours of indoor activity must be counteracted by 1 hour of outdoor activity. That is what I am telling every child. I have, that is what every child. क्या हुआ भाई? That's नहीं वीडियो है ही नहीं यार इसमें तो. I don't know what क्या बीच में क्या हो गया भाई तुम्हारे यहाँ से. ये हैंग हो गया इधर. हाँ अब करो. Yeah, ठीक है. So what has been now postulated that 6 hours of indoor activity if you do must be counteracted by 1 hour of outdoor activity. So you must always tell the small child that you should always go out in the open air. Oxygen is one of the important things which they are now also talking, that the eyes should get oxygen. If they get oxygen, the pathological effects of elongation of the eye is not there. I mean, there have been lot of theories, lot of work, lot of papers on this, how much of near activity, how much of outdoor should be compensated with that. But oxygen, outdoor activity is now been definitely has been now proved. Then lifestyle changes. See, we have totally, the lifestyle has changed. We have succumbed to indoor activity, computers, laptops, mobile phones. There is too much of strain on the eyes, the muscles, the accommodation, and dim light, artificial light. They say that there's been a lot of papers recent last year in the American Academy. There was a very, very important paper on illumination. They said natural light, which is white color, is more beneficial than a colored light. So we are doing on fluorescent, working in fluorescent lights, which is also harmful to the eyes. I mean, this is all research, which comes at what is good, what is bad for the eyes. So one thing is nearby, which I told you, illumination, food habits. Yes, high protein diet is recommended for to inhibit the progression of myopia. Gadgets that generate radiation, another important factor which should be removed. Then the major stress now is laid on the pharmacological agents to control the progression of myopia. Now, atropine has been used, and there's a lot of research. AIMS is also doing on atropine. I am also recommending atropine. There are almost 5 centers in India which are working on this atropine. It started with 1% atropine, then 0.5%, 0.1. Now it is proved that 0.01% of atropine is the standard regimen for treatment to stop the progression of myopia. It does not act on accommodation. It does not cause mydriasis. It acts on the retina, sclera and the choroid. It acts on dopamine. It helps in liberation of these very, very small percentage of diluted atropine increases the release of dopamine, which prohibits or hinders or checks the elongation of globe, and also controls the defocusing mechanisms, so that a lot of work has been now being done on hyperopic and myopic defocus. Defocus means if the eye is hyperopic, it tries to enlarge, but it is not the vice versa. That once myopia has occurred, if you try to produce hyperopic, myopia, the eye will not become small. But in hyperopic eyes, there is an hyperopic defocus. The focus is on the back, and therefore the eye tries to enlarge to compensate to have that fixed on this. Pirenzepine is another drug which is available in India. Atropine is coming by 3 companies now. Atroped, Myopin, there's another. There are 3 companies which are making atropine available in the market very, very Pirenzepine, another drug which is also available in India. It is a 2% ophthalmic gel used twice daily. And then methylxanthine is another drug which has caused the inhibition of progression of myopia, 400 milligram daily dose, starting from 3 years. But all these act only up to 18 years of age, that is there. So with that, I'll conclude. Thank you very much.
That was fantastic, Dr. Shukla, and he actually told you that atropine is not only for the ulcers, you can use it for the myopia control also. But still, it's a controversial thing. How did it actually work? I mean, there's some hypotheses put across. Does it work in all the patients? Does it have to be a specific genetic predilection of the patient to work on that? Not known. Although all the Eastern countries, Singapore, Malaysia, all are myopes. So if you start this, maybe another 5 years, you'll not see myopia at all. But I think it's still to stay. No, I'm taking next. कैमरे में ठीक है आराम से आ रहे हैं भाई से 8:30 बजे मैं लगा before 5 years it's very rare, it's very है नहीं लोग यार अच्छा अच्छा रिकॉर्डिंग के लिए तो so if the myopia has appeared before 5 years, it's going to progress. So as a matter of fact, every patient I start atropine 0.01% as soon as it detects myopia, because it only acts up to 18 years of age. उसके बाद वो act नहीं करती है. So एक चीज़ तो ये हो गई. दूसरा is very unusual कि 3 साल से पहले कोई बच्चा है. You can start even after 1 year. There is not a problem. You can start even at the 1 year of age, because it is not harmful. It is not कोई accommodation को, it does not create accommodation paralysis. तो आपको कोई amblyopia होने के chances भी नहीं है. ठीक है ना, क्योंकि अगर आपने एट्रोपिन यूज़ कर ली तो एम्ब्लाइपिया हो जाएगा बच्चे को. तो it is, that's why you can start. Yes, sir. But I think it's a good question. He says that if you start in a child and you dilate his pupil, do you dilate in this one? So will the peripheral retinal blur reduce or increase?
It does not dilate the pupil. 0.01 does not dilate the pupil. That's the whole thing.
No, but the attempt 2 said that efficacy of 0.01 is not as good yet. Yeah, that's what I'm coming to, because if you go see all the studies follow up, and do you want to stop this ever, or you will continue lifelong? So up to 18, or when you start feeling that the myopia has become stable? When the number doesn't change, when the number does not change more than 1 diopter in 1 year. So you're getting hooked on. So it's not Chow, her name is Audrey Chio. So that lady is the one who's done the maximum work, and she's a personal friend, and she also says that when you stop, it goes back. I think Leila also met the lady, yeah? The short lady from Singapore. But the issue is that we are trying to ape that without having the protocols in place. So if you want to start these protocols, you have to have stringent control, have a good follow-up, and every time you do a excellent measurement, and what you need is a good OCTs like a swept source, you can be very precise in picking up the excellence. So if you have an error of say 0.1 or 0.5 of excellence every time you do it, you don't know whether it's because of the errors of the machine or because of the myopia. You get my point? So when you want to say something which is effective, you need a long-term study with a very, very good meticulous follow-up. Otherwise, there's no point in jumping into this one. Is it good? I got a patient in my OPD following up by a practitioner in Delhi. So he started atropine 1 year down, and the kid was using 1% atropine, pupil fully dilated.
So that is not recommended
That's
now.
ridiculous, because the starting is without having, this has to be institution-based studies, and once you come out with the idea, then only should have come in the market. I don't know why these people are so keen to come to the market to make money. It's not good. It's not really good at all. Yeah, Laila, please.
Still not FDA approved.
Absolutely right.
Actually, one of the thesis of our PG.
It will reject. I know. It will get rejected.
No, but not FDA approved, but it is, people are using in Europe, they're using in England, they're using in Asian countries. Yes, Dr. Sudarshan Kokar, we must all congratulate him. He has been awarded the highest award of our IIOS, PC Varity International Award.
Yeah,
we must all give him a hand.
That's okay, I think. That's for the pediatric cataract work, which I've been doing for the last 30 years. So I could have got it 10 years back, but it's okay. Later than... No, I don't work for awards.
Better late than never, yeah.
The awards are not my stimulants. I mean, my good patients, happy patients, smiling patients.
Yes. So
are
Dr.
my stimulants.
Sudarshan will be speaking on evaluation of pediatric cataracts. His
Right.
Close to his heart.
Yeah, it's always there. So when it comes to the pediatric cataracts, the first thing the parent asks is, how come my kid has got a cataract? Cataract is supposed to be disease for the old, elderly. I mean, all my grandfather had it, my father had it at the age of 50. How come this guy is 6 months and you're saying he's got a cataract? Then he goes to one doctor, he goes to the second doctor, he goes to the third doctor, and eventually they say, go to Kokar, he's the best. So they all land up with me. So what you're supposed to do in a one simple test, which Dr. Pradeep Sharma also said, you put a drop of dilating drop, one in the eye, one drop in both eyes, wait for 10 minutes, take a distant direct and see. You'll pick up most of the things. I'll show you the videos, I'll take care of all the doubts. So I'm talking about evaluation. I'm not going to show any videos, which I love to show off, but this is not the forum for that. So why are we talking about that? Now there's an epidemic of this also. The pediatric congenital cataracts are on the rise. We started this clinic about 25 years back. I used to get 5 patients in a month. Now I get 25 in a week. So that means 25 into 4, I get 100 in a month now, which I was getting 4. So you see the multiple factor. One, because ours is the referral center, so we get all the patients referred. Second, the traumatic cataracts has gone up. Diwali, Dashera, crackers, kids injuring their eyes, they also come to us. And one child, if you operate properly, is equal to 10 adults. Because this child, if he's blind, will need an attendant. So these 2 people are not working anything for the GDP for the country. So they're taking care of the child for his daily activities up and down. So 2 people are gone. All right, with our population, it's not good. So in US and all the developed countries, it's about 1 to 4 in 10,000 may have congenital cataract or the lens lenticular abnormalities. Whereas in our part of the world, Africa, Asia, you have about 1 to 15. It's about 15. So every 10,000 patients, you'll have 15 patients who are going to have cataract. So with that, there are 200,000 people blind because of cataract. I'm talking about children only. And this was a study of 10 years back. So now you can just multiply it double. So there are kids there who want surgery. So So this is why this topic becomes very important. Even if you don't operate these patients, you should evaluate and send it to the person who can manage it. Okay, so this is a figure all around. USA also has share of problems because there's an immigration of populations coming from Mexico and India and everywhere, and those people are genetically sometimes predisposed for cataract, and so they get it. Australia has few. Cameroon is the worst. India, we did a study in which we found out that we did a cohort study at the RP center in which took 1,000 patients for 1 year, and we realized that out of those 1,000 patients, about 50%, 45% were the congenital cataracts. Second was a traumatic cataract of 30%, which was totally avoidable, not needing any surgery, no vision loss, if they have taken care of the child while they were playing with the crackers and bow and arrows. Okay. The last group here is 7%, which is it's done by the surgeons who don't know what they're doing. So they just go in, puncture the anterior capsule, put in the lens, and they come back with the opacity. We have to deal with those patients also. So with that in mind, the 2020, the WHO decided that the childhood blindness is important, so you have to take care of this one on war footing. So preoperative evaluation, I think the most important is the counseling of the patient in this one. If it's a bilateral cataract, you have, even if you don't examine the eye, you're going to be fine, because 90% of the bilateral patient will not have any ocular problems besides cataract. Whereas the unilateral cataract, 99% of them will have a local eye problem. So you have to evaluate the eye. It could be a smaller eye, it could be a smaller cornea, it could be a shallow chamber, it could be a retinal detachment, it could be a tumor in this eye, or it could be a persistent fetal vasculature, which is a part of the normal growth of the eye, but it regresses by 21st week. So if it doesn't regress by that, it'll stay. So unilateral cataract, look in the eye. Bilateral cataract, look in the body of the patient to find what is the cause, right? So that's very simple. So as Dr. Sharma said already, that you have to look into that. So patient might not sit for, so this is what is Cardiff visual acuity. Now this guy is bilateral cataract operated, and he's so happy when he sees the figure and see the response he gives. You have to be patient with these small patients. These small patients needs more patience, and there's if the child cries, half the work is gone. And if you see the ocular movement now, if you have a nystagmus, now see this patient's eye, and you tell me which direction the eyes are going to. They're going up and down, up. He's trying to fixate. He goes to the sides, and then he comes again. So do you think he can see? Of course he can see. He can see. So if he can see, that means this is the patient who should be given a chance, despite the fact that his visual ocular movements are not good. So if ocular movements are not good, there was a study which we did at the RP center. We did a video recording of this one before surgery and after both eye surgery. We found that the amplitude of the nystagmus goes down. It is never going to disappear. It will stay because it's already got into the nerves, and the nystagmus is not going to disappear ever, but the amplitude reduces, and that we have already proven. Okay. Then you dilate the patient, and have a look. Now, so if you see a white reflex, there could be three possibilities. It could be opacity in the lens, so you send it to a cataract surgeon. It could be anterior problem. It could be a glaucoma. It could be a corneal issue. It could be a Peters or a Reger's anomaly with a corneal involvement, or a mucopolysaccharidosis, any corneal lesion. So you send it to the cornea person, right? So if you're smart enough, the patient will not have to make 2 visits to the hospital. He can get his work done in 1. And if there's a problem at the back, so how do you pick this up? Do ultrasound. In these patients, you can find out where it is. Or if you're smart enough, now see this patient. There's a white reflex in both eyes. It's whitish, grayish, but white, more white. What about this one? This is more of grayish reflex. So this was sent to me as a cataract bilateral, but it turned out to be both eyes leukocoria with a retinal detachment of both eyes in this patient. Now just see this video. Now this is what is Bruckner's reflex we're talking about. You see a red reflex here? Red, yellow, white, and they keep changing. So if your reflex is changing, that means it's a mobile thing. Whatever is blocking the light is mobile. So it could be a dislocated cataract, but in this one, the lens was not dislocated. So it has to be in the retina. So if you see at the different angles you can see red reflex in both. So this was the patient with the ROP, and you see at the end, both eyes are giving a glow. When we started, it was white. So if I had jumped into the surgery in this patient for cataract, I would have been wrong, because this was not a cataract patient. The lens anterior part was all clear, it was at the back. So it's a simple test. Be patient with the patient, and you will get the benefit out of that. So you can have local involvements in the eye, anterior segment problems and posterior segment problems. You can check up in the literature, nothing great about that. Now, these were the risk factors which are associated. You can have a torch infection, especially the rubella and the toxo. Rubella, toxo are the one which can give you the cataract, not any of the other ones. Galactosemia gives a cataract. You can have low birth weight. You can have hypoparathyroidism. So we added one more thing in the RP center. Ankur, we started taking the head circumference of the kids now. And we realized that the one diopter, standard deviation off was about 60 to 80% of patients' kids were smaller heads, but they were normal. And if it more than 2 standard deviation becomes microcephaly, which was again about 25% of the kids. So that's a typical example here. You see it's a small head. This one looks small body, but the head is big. So that's a hydrocephalus. So you see the height of the patient, age of the patient, and see the head circumference versus this one. So these are typical examples. If you see these patients, you have to have a neurological opinion in both, because this could be a rubella with the involvement of the cortex, and that again, of course, because of increased ICT, you have issues. Okay, so you can have syndromic kids. The commonest is Downs, and the rest goes down. So there's a new syndrome which has come up now. So when my patients come to me, I dilate the parents also, and do a reflex, distant direct reflex in parents, mother, father, both, and the kid. I don't see the kid when both the parents are there, because I can refuse them, because I'm sitting at a place where I can. So when we saw this kid, if it's a male child with a mother having cataract, something like with a small cataract, either zonular or at specs, so it could be a Nance-Horan syndrome, which is X-linked ones. And we picked up about 5% in the last 2 years, we had Nance-Horan syndrome. So the mother will not have a vision loss, but she'll have cataract specs. And the typical thing here is the anteverted pinna, which is like ear going out. The movie called PK, you've seen that guy with the ear like that? So that is called anteverted pinna. So if you have a cataract in a child with an anteverted pinna, please look for mother's eye also. You might pick up, you might be surprised. So that's mother's eye, but vision was 612, she's happy, she's not bothered. So we also didn't bother. This patient, the limbs was shorter, and this was very typical. There's only 3-4 cases in the world, but if you pick up things like these with a cataract, please send them to me. I'll take care of that. This is Conradi-Hunnemann syndrome. And this cataract was a little different because it's not a typical zonular in the one place. It's got one zone and the second zone. That means it has 2 hit hypotheses somewhere. So you're just looking into this cause. Don't have to go in that much in detail, but if you pick up a mediopacity, please send the patient. Downs, I think everybody knows about. So galactosemia, if the patient is born with jaundice and has a cataract, please err on galactosemic diagnosis in 100% patients. You may be wrong in 5%, but those 95% you'll save their life, because the mothers will keep feeding the child, and the child will thrive and he'll die because liver and everything is involved. So you try to save these kids. And if you can start them early on diet, proper diet, you can reverse this cataract also. I'll just take a minute here. Rubella, we all know. All right, so this is a battery of tests which you can do. If you have resources, you do it. Otherwise, please do a clinical examination, do a good Bruckner's test, and send the patient across to the higher centers. We picked up around 4 new genes at RP Center, in which we found out that beside these, we have some more also. So this was published, and I'll show you some pictures. So this is a cataract, typical zonular cataract. These are blue dot cataracts. Since the glow is good, you don't operate these ones. And this again is a blue dot cataract. Okay, now, these are quadrantary cataract. Is something like a party is going on and the party got over. So we just got one piece of pizza left in each eye. And this is not drawing, it's the actual patient's eye, right? And this was actually the party just started. So people have just taken one piece of pizza each and the party is going to go on. So this needs surgery. Then you can have a lenticonus, you can have all these funny things. So this you can see if you do a distant direct and a Bruckner reflex, or a reflex through the distant direct, you can pick up all these findings in the patient. So that reflex is very, very important. That's a sutural cataract. That's anterior polar pyramidal. And the traumatic ones are the bad ones, which they're totally avoidable, and people should try to work them out. And the most important thing now I'm going to tell you is examination anesthesia. If you have a child and the child is not cooperative, you can't comment on anything. There's no point in holding the child down and opening the lids and putting in your instruments. It's not going to work. So you have to put the child under anesthesia. So you need to have a very good anesthesia team who can keep these kids happy and healthy. So that's what we're doing, a keratometer, and then we do the axial length and do the white to white measurements just before the surgery. So all these kids, and if the child is not cooperative earlier, we can do ultrasound B scan also here. So we're doing a white to white. So this tells me that for all the pediatric kids, if you're not comfortable, please do not comment yourself. Whenever you put a finding, you put a query till you've done the examination properly, and then we can go ahead and do the surgery in these patients. And these are the instruments which all of you should have if you really want to do the pediatric cataract eye surgeries. And so sometimes you get patients like this. Now, this is the last video. Now, this was in the eye, in the front, and this is not a silicone oil bubble, right? This is a crystalline lens in the front, homocystinuria patient. 8 years old, lens in the front, we have to take this lens out, okay. So to conclude, I think diagnosis of congenital cataracts is imperative, and comparison history has to be taken from the parent, injury, everything, and the family history of siblings and the pedigree. The fathers, grandfather, grandparents, you can get them done. Ocular systemic examination should be taken care of. Basic examination should be done under anesthesia if possible, otherwise without anesthesia. Preoperative investigation should be done before you order the lenses, because on the table, if you find out your exit length you thought was 16, it turned out to be 19 or 14, you can't ask the patient to come out because he's on the table, so you please plan it in advance. And you have to plan and do the biometric calorimetry if you're planning the IOLs. Right, thank you very much. Sorry I took 2 minutes extra, but I thought that was needed. So we got the last speaker now. Mukesh, I don't think is coming. So that's it. You can ask me questions after the end of the session. I'll be here.
Very good morning. And I'll be talking on measuring the IOP in children because that's a different aspect we all know is important. Okay, great. So this time it is working. It was not working in the last session. So IOP in children. We take the, in adults we don't get the eye examination complete without an IOP. But then why do we accept children without an IOP? Because there are many challenges: level of cooperation of the child, wakefulness, efforts to close the eyes, anesthesia required, and then there are various levels and drugs used, and the use of speculum. They all alter the IOP in children. So whenever we have a patient under anesthesia, the airway is very important. If you use the face mask, it is going to put pressure and in your area, so it is difficult to examine the child. Intubation causes rise in IOP for up to 5 minutes, and laryngeal mask anesthesia is the most preferred way if you are doing a child in anesthesia. Inhalation agents do also affect the IOP, like halothane, sevoflurane, isoflurane. They all cause decrease in IOP by various mechanisms, including suppression of aqueous humor and central control of IOP. Propofol, thiopental are the commonest inducing agents. Propofol is a non-barbitrate and thiopental is a barbitrate, and most studies say that they have no effect on the IOP in case of propofol. And some studies do say that they can have slight decrease in IOP by 40 to 30% in adults. Now, this ketamine is another drug which is commonly used, and we all feel that the ketamine causes rise in IOP. So there are certain studies which say actually there is no rise in IOP with use of ketamine. Some of them do say rise in IOP with ketamine, and one of the study in fact said that there is a reduction of IOP while using ketamine. Midazolam is another drug which is also used in sedation and anesthesia. It has no effect on IOP, but there are certain studies which claim that there is reduction in IOP when the midazolam is used in children. Neuromuscular blocking agents, if you're talking of succinylcholine, which is a depolarizing agent, it causes an extraocular muscle contraction and direct effect on the aqueous humor dynamics. This can cause significant rise in IOP. And non-depolarizing agents like rocuronium, atracuronium, they actually cause slight decrease in IOP, rocuronium having the greatest propensity to cause decrease in the IOP. Now, this is a table which summarizes the effect of various drugs used in GA on the IOP, like chloral hydrate has minimal effect. Midazolam, atracurium, rocuronium, propofol, and thiopental have mild to moderate reduction of IOP. Mild reduction of IOP is with oxygen and nitrous oxide. Mild to significant rise in IOP is with halothane, sevoflurane, and isoflurane. Minimal to mild increase in IOP is with ketamine, and marked increase in IOP is by succinylcholine and intubation. So whenever we intubate the patient, it is always recommended that we should wait for more than 5 to 6 minutes and then take the IOP. Now, what are the values? The values also vary from birth to the adulthood. So this is a study which said under the GA, if you use the Perkins tonometer, a child is less than 3 months of age would have IOP of less than 8 millimeters. From 6 to 9 months, the IOP would be less than 12 millimeters. After the 9 months of age, there is an increment of IOP with 1 millimeter of mercury per year till the age of 12 years. And after the 12 years, the IOP range is in the adult range. Now, there are various tonometers. All of them have their pros and cons. The commonly used for children are GAT, Perkins, Tonopen, Rebound, and Schwartz, which has a questionable value these days. Goldman applanation tonometer is ideal as in case of adults, but it is a little scary. Something would come and touch the eye, would scare the children, but it may still work for older children. Like this is a child around 7 years of age. She's getting an applanation tension done very comfortably. It is not suitable for small kids, and it cannot be done in the supine position. Perkins is ideal. It is best suited. It is reliable, but it has a learning curve and cost involved in it. Also, the availability is a problem because most of the private practitioners may not have this access to this Perkins tonometer. Impact rebound tonometer does not require a sit lamp and it is less intimidating. It is effective in younger children. You can make the children sit and you can take the pressures very comfortably. It can be used in OPDs as well as operating rooms. It's a small portable device and people even say that it has been used for the home tonometry readings. Now this is a video which is showing IOP reading under GA where the patient is in fentanyl, midazolam and propofol, but this is wrong because here the speculum is applied to the eye. This will cause false rise in IOP. This is another video which is showing you the correct method of taking the IOP. The patient is under fentanyl, midazolam, propofol and isoflurane. I don't know why the videos are not working. And this is the rebound tonometer where the child is getting himself examined in the OPD. So we can see the child is very comfortably getting the tonometry done. Now there are various studies which compare to rebound tonometry with Goldman applanation tonometer. This study says there's the rebound tonometer range is a little higher. The IOP measured is a little higher by a factor of 2.3 millimeters. Another study says it records mean high pressure of 3.1 millimeters, and another study says the IOP recorded by RBT was about 1.96 millimeters higher than Goldman applanation tonometer. And this study says that a lot of children, 79% of children, got the IOP checked by rebound tonometer, while 30% of children could get it by the non-contact air puff tonometer. So the air puff tonometer is also difficult in children, and rebound tonometer can be used in these patients. Now, this eye care tonometer now is available even in the supine position. You can make the patient supine and you can still take the pressures. TonoPen combines the principles of applanation and indentation. It has similar measurements in the normal range of pressures, but it also has a tendency to overestimate the IOP as compared to Goldman's. The tip is a little bulky and it is again having similar problems and concerns with children as the Goldman applanation tonometer has. Non-contact air puff tonometer does not require topical anesthesia, but air puff can frighten the children, and then they may not even actually open the eyes in the autorefractometer, so that may actually cause a problem to us. Again, the IOP measurements are less reliable. Shiords has a questionable value. It is not preferred these days, but because there are better tonometers available, and it is more so less accurate in children because of the decreased scleral rigidity in children. So the principle suggested for doing an examination of anesthesia in children is midazolam can be used for sedation as it does not have a significant rise in the IOP. Inhalationals, agents like sevoflurane and isoflurane are preferred because they reduce a very mild amount of decrease, they cause a relatively mild amount of decrease in the IOP. If intubation is performed, we should wait for at least 6 minutes before the IOP measurements because intubation causes rise in IOP. Applanation tonometer by Perkins is the first choice. If the Perkins is not available, then TonoPen and rebound tonometry can be used in patients under anesthesia. And wherever possible, we should use the same device, the same anesthesia protocol, the same drugs, whatever we are using, and the time after the anesthesia which we have taken in the first anesthesia should be repeated so that we can have the similar kind of readings. Speculum should be avoided because it can cause rise in IOP, and IOP measurement should be done before the pachymetry, axial length, and scleral indentation because again they can cause fall in the IOP. Thank you for your kind attention.
Thank you. I think you covered it all. So especially on these. Yeah. So to see whether the medication is working or not in a specific patients, you have to do the same, as you said rightly, the same time, the same anesthesia, and the same amount given before you actually start checking the pressures. And still you can have errors, yeah? And he's rightly said that applanation and anything contact with the kids is a big no-no. So I think the eye care has come out a big way because we used it in Australia earlier and now it's come to RP Center also. The only thing is you have to change the tip every time you use it. In India, I think you start using it again and again in patient, but it's not advisable. So I think the cost could be a factor, but if you really want to give a good care, you have to give them this best possible. Any questions on this session so far? I think we can close the session. Ankur is here. Mukesh, no time now. Sorry. So, any questions?
So you can take questions, sir.
I think the audience in the beginning was different. I think these people must be those die-hard fan of the refractive surgery which is going to follow now. Are you guys? Yeah, I can see one girl with the spectacles there. You haven't thought of getting the refractive done? Talk to the guy next to you. Talk to the guy sitting next to you. He'll help you out. So any question I was seeing question on the Bruckner's. If you have any confusion, I can help you out. So I told you about the Panam's area and the horopter. So that is the basic concept, and that's what you want. Even if the vision on both eyes is not equal, If there's a difference of 2 or 3 lines also, you can still have the depth perception, but provided it goes more than that, if it's more than that, if the deviation is more, the moment the points lie outside the Panam's area, you can't fuse them. So that's when the problem occurs. Then one eye which is not in that area will go into amblyopia. And if you are still in the fusible range, you're good. That is a good question. And anybody, Leila, you want to add on something? I'm sure, because we're doing all these myopia studies and all, but as you rightly said, the FDA has not approved it yet. And there's not enough evidence yet. Otherwise, maybe next 5 years we see all the Chinese and Japanese without... I ask you a question. Does a fish eating cause myopia? Because all these bongs, and you go from this side, go all the way to China, Singapore, they're all seafood eaters. So they say it's good for health. I mean, let's put it other way around. I mean, why don't we find out that it's a fish which is causing it? Cause and effect.
Maybe there is a specific species of fish.
I don't know.
fish.
Yeah, sorry.
Statistics in our part of,
Can you use the mic for the lady, please? Thank you.
our part of Kerala shows that myopia incidence compared to even the other statistics in India is very low.
Yeah.
It is less than
Yeah.
1% of the population actually.
True.
So I think it has something to do with the flat system. The flat, it is mostly outdoor activities
Yeah.
are definitely more in schools and even otherwise in.
Of course, I think that's
But
very
the
important. So
Kerala
outdoor-
also has a lot of fish-eating people.
Yeah.
Yes, of
so it's
course.
not the fish, I was joking. So basically what happens in these ones is, there was a study which was done and got a big prize for that, in which they put a person in a dark room. And they put him for a week's time, and they realized every third and fourth day he was losing 1 hour of the time. We used to ask him, what's the time you think it is? So initial 24 hours he could keep a track, and afterward he lost it. So that means the more you stay indoors and don't go outdoor, your circadian rhythm goes for a toss, and that has something to to play with this one. So the other thing is, if you sleep with the lights on in the room versus lights shut in the room, there are lots of studies going on the myopia. So let's see when they come out, and we'll find something fruitful. And Leila, thank you very much for putting those good comments. And with that, we'll close the session so the refractory guys can take over. Shashi Kapoor, Shami Kapoor, and Prithviraj Kapoor. Are they here? No? So next session is going to be starting now. Anybody, any question in the meantime? It's a Mumbai, I think. I'm sorry, the breakfast session didn't have breakfast. I thought it had breakfast, because in the US and Australia, when they say breakfast session, that's meant for people to come and eat along with that. Lunch session has lunches, so why can't the breakfast session have breakfast? So all of you should put a letter to the DOS AIOS people. The money is enough with these guys. They should have given you breakfast. It's not that you can't have it in a hotel, but if you come here, sit while having, you can discuss what's wrong. We have enough money. We can give 40 lakhs to that lady not to perform yesterday. Kya naam tha uska? Bruna Leila? Sorry, not Bruna Leila. Sunidhi Chauhan. So why can't... I know, I mean, I'm reckoning badly to that, because you're paying 40 lakhs rupees for what? No, it's not done. And thank you very much.
Thank you, everyone.